So let me, without further ado, introduce C. Daniel Mullins. He's a professor in the Pharmaceutical Health Services Research Department at the University of Maryland School of Nursing, or excuse me, School of Pharmacy. Sorry. Sorry, Dan. His research and teaching focuses on pharmacoeconomics, comparative effectiveness research, patient-centered outcomes research, and health disparities. He has received funding as a principal investigator from NIA, NHLBI, PCORI, and various pharmaceutical companies or manufacturers, including Pfizer. I think I slipped a little bit in saying that he was from the School of Nursing or nursing. He is a he is a great collaborator across disciplines and advancing research that's important to patients, to practices, and to our communities. So please help me in welcoming Daniel Mullins.
Good morning. There was this young lady, and she met this rather charismatic gentleman. Well, the two of them hit it off quite well. They spent some time together, and eventually, they got engaged. The young lady's friends weren't so happy about this, and they told her, "Don't trust him." You see, the young lady and this charismatic gentleman were from different walks of life, and the young lady's friends felt that she shouldn't trust the gentleman. Well, time passed, and eventually the big event occurred. The young lady's friends attended the big event because they knew it was important to her. They went there to support her, and the event was stunning. A few days later, the charismatic gentleman left. It's been about a year now, and she hasn't heard from him. If this story were about engagement for a wedding, most of us would think that the gentleman had done her wrong. So what if this is about engagement for research? How many of you know this young lady? How many of you know this young lady? How many of you have met this young lady? And I've asked to take the liberty of making this a dialogue today, not a lecture. So I'd like to hear what you know about this lady or what you've seen. And so can we pass the mic? I see one hand over here, and we'll come to a couple people. Because I think it's important for people to tell their story so that we can learn from our stories. And I know that one of you is brave enough to tell a story about this young lady. Anyone? I know that some of you know her, or at least you've heard her story. Here's one over here.
I have my coffee in my hand. So in Southwest Detroit, in the late 1980s, the University of Michigan, a faculty member from the University of Michigan came who was interested in knowing what teen youth understood about sexuality in order to inform the AIDS, developing research for AIDS. And they came in and they collected, or they were interested in collecting data from these kids to pass surveys. And at that time, Latino Family Services had a group, a piece of it called Vida Latina that said, no. We need to have some resources left here in the community because we know what will happen is that you will take the information from our teenagers and you'll go back to the University of Michigan and publish it, and we will never have any meaningful results or impact here, and we won't be full partners. So that was the setup, and indeed, it wasn't, the unhappiness wasn't that the partner did leave, the gentleman did leave, but in the process left about $25,000 for a health educator in the community because of the advocacy of the lady.
Well, and thankfully that there was someone in the community to stand up and have their voice be heard. That was a great story. Another story? Anyone else willing to share? It's early. If you don't share now, I'll make you share later. I tell my students this, questions only get harder. Anyone else? I'm going to talk about this today. I'm going to talk about this today. I'm going to talk about the way in which we need to make sure that there's a commitment. I'm going to describe a 10-step framework that I developed with some colleagues for patient engagement that drives home this point of continuously being there and re-engaging those with whom we say we're going to partner to conduct patient-centered outcomes research. The word trust is going to come up many times in my talk today, and my guess is that it will come up in many of the conversations that we have today. And then I'm going to speak specifically to some work that I've done funded by the Patient-Centered Outcomes Research Institute, or PCORI, about approaches to engaging hard-to-reach patients. I have a disclaimer, and so I will say that I'm very thrilled with the funding that I had from PCORI. I'm also thrilled to be one of the early recipients of a Patient-Centered Outcomes Research Infrastructure Development grant from the Agency for Healthcare Research and Quality. I will sometimes use the words hard-to-reach patients, even though I cringe when I say that, because that is what we were funded to do with that contract. And for those of you who also cringe, let's just agree that it's those individuals who typically are not engaged in research and how it is that we can outreach and truly partner with individuals from those communities. In addition to thanking my funding agencies, I have a long disclaimer that I'm required to put up. So I'll paraphrase. Essentially, anything I say that's silly or might offend you is from me, not from the agencies that support my research. And I think that they're very glad because they know how I speak sometimes. Anything I say that's brilliant, though, you can attribute back to them. What does it mean? What does it mean to really engage individuals? And I love the term being there. It's one of the things that we learned from the communities that we partnered with. But really to think about comparative effectiveness research as being helping individuals to make decisions when there are alternative ways of receiving treatment in diverse populations with information about the outcomes that are important to these diverse patient populations. And that if we do that using human beings as advisors, not just as human subjects, so that if we truly engage individuals who have a condition or who have a loved one who has a condition as advisors, not just as people we study, but as advisors, I believe that we get to patient-centered outcomes research. It is a continuous process. One of the things that we learned was that most of what we need to do has been discovered in community-based participatory research before, but what's really new is we've never applied it to comparative effectiveness research before, and that's what's exciting. But as with community-based participatory research, most of us don't get engaged the day that we meet someone. Most of us don't get engaged the day that we meet someone. And so there is this pre-engagement period in which we get to know one another. And that could be an institution like the University of Michigan and a partner in the community, or it could be either of those two entities with an individual patient. And I will talk about the need to really think about pre-engagement, not just engagement. And I will always come back to the essence of thinking about diversity. And I'll start out by saying that when we talk about diversity, it cannot be about the box that's required to be filled out for your application. It cannot be about just gender, race, and ethnicity. Because as we've heard many times, there are lots of people who are from underrepresented populations who are not at all hard to engage. There are lots of people who come from those communities who are not hard to engage. It's about meeting with those individuals to get to the people who are truly hard to engage, right? That's the higher vision that's beyond the numbers and into truly seeking to get diverse input. And I'll talk to those of you who are researchers about why that's so important, even if you're just a statistician. Because statistics and evaluation is about studying variation. And if we don't have variation, we don't have much to study. Why is patient engagement so important? What I have learned from the patients whom I've spoken with is that we don't know how to frame questions as researchers in a manner that a patient will understand. But if we take the time to talk with an advisor from the community, it may take 20 minutes, it may take a half an hour, it may take 3 months. Once we find a common ground and we can get an individual from the community to give us back the real question, it's amazing how that transforms our research. So that it's no longer my question, it's a question that patients have. And if it's a question that patients have, then when we get an answer, it's much more likely that the answer will be an answer that a patient seeks, not an answer that a researcher seeks. And this patient engagement, therefore, allows us to frame a question so that it's understood. It allows it to be appropriate for the individuals who are impacted and the culture that's affected by this. We hear oftentimes this concept of meaningful. And so I've struggled with this because we could simply mean that a patient literally understands what a question is. But I would say that we want to go beyond that. It's not just that I understand it, but that it has meaning in that it would impact me to know the answer to that question, and that my behavior might change if I knew the answer to that question. That, to me, is the essence of a meaningful question and meaningful answers to patient-centered outcomes research questions. If we do that, this talk about activation of individuals being more involved in their care, well, I think if patients had better answers to their questions, not my questions, that individuals would be more empowered to do something with that information. So there's lots of reasons why we want to think about patient engagement. For those of you who are in public health, we're talking about the health of the nation. We do it one patient at a time, but the public health of the nation is simply the sum across approximately 300 million of us and what's happening in this country. And for those of you who do global, just multiply that tenfold, or however many people are in the world. The truth is there are important gaps that we want to answer. We talk a lot about evidence gaps. And I think if we engage individuals, that for the health of the nation, that communities can help us to prioritize of those important questions, which are the ones that we will answer today, which are the ones will we put off till next year, and which are the ones that maybe a researcher finds really important are not so important to the health of an individual patient or to the health of the nation. And that we could use our resources more wisely to answer the questions that are most important. We have to think about this from a pragmatic sense, though. And I love the way in which Pecori thinks about this. Because on the one hand, if we live in a democracy and we want to suggest that we should vote on what are the priorities, it's possible that the prevalent conditions and the prevalent populations would get their questions answered. And so it is important for us to also think about rare conditions and subpopulations and making sure that those important questions don't get overlooked because a democratic process might lead to the majority deciding that their question is the most important one. So we have a lot to do with patient engagement to help us think through those pretty important questions about where is the government going to spend its limited resources in generating new evidence and disseminating that evidence. Finally, I think it shows a genuine commitment. And one of the things that I know is that we might think that the community isn't as smart as we are, but people know when you're sincere, and they know when you're faking it. They know when you're sincere, and they know when you're faking it. And honest and transparent engagement transcends the way in which we do research. And if it's not, then you get the same answers that you got last week, despite the fact that the question is a little bit different. Right? And I think that that's the most important reason. If we are sincerely trying to answer a question, we need to have an honest commitment to finding out the truth and to taking the steps that would be required for us to get the truth. For those of you who are new to this, one of the things that we all know is that we need to meet people where they are. Okay, so the microphone's going to go around again now. What does it mean to you to meet patients where they are? What does it mean to you? Because the words sound good, but what does it mean? What does it mean to meet a person or a patient where they are?
Hi, I'm Bishop Bernard O. Jefferson from Flint, Michigan. Caution, to meet a person where it is to know their culture, to understand that different people come from different cultures and different environment, and you just can't approve one person and say that's what everybody is alike.
That's great. That's great. Because I think the 101 of this is, I'm willing to walk to your church. I'm willing to go to your community center. And there is geography. But I love what you just said about it's understanding a person's culture and what that means for how they make decisions about health care and other important decisions for them. Anyone else about this question? What does it mean to meet a person where they are?
Hi, I'm Jean Du Russell Weston from Project Healthy Schools. I think that from the researcher standpoint, it means to first meet the need of the people that you're working with before you put whatever your intervention or your agenda is on them.
That's great, right. And I think that speaks to the pre-engagement, which is understanding that this is not just about being a taker. It's not just about helicoptering in and getting what you want. Great. There was another hand in the back, and then we'll come over here.
My name is Janice Muhammad. I'm within COBRA and CBOP in Flint, Michigan. I really appreciate what you said about getting with the groups, the leaders, the organizations within a city or a place, and then going through them, because I feel like the researchers can't know that community if they're just coming there.
Right.
So if you go to the people that know their people, then you've actually tapped into that avenue there. And to get to know the people, to get to know where they are, I think it's really the job of the organizations that you work with, the grassroots organizations that you work with. And I appreciate you recognizing that.
That's great. I'm going to go on, because I'm going to leave some time at the end for more stories. But the reason I want to go on is this woman just spoke to my next slide. For those of you who think that this sounds scary, the good news is that there are so many leaders in the community who are willing to help. It's just amazing. And so first, shout out to Flint, Michigan. I've heard from 3 of you already, and I know that for me that's just wonderful. Many of us who are not from this state have seen Flint, Michigan on TV, and to meet you in person, thank you for coming. Thank you. And thank you for being leaders. And I'm not talking about titles, I'm talking about being a leader. Thank you for the leaders who help those of us who fumble our way through doing this. Thank you for those of us who are willing to give us what we need to know so we don't embarrass ourselves or our institutions as we walk in. And thank you for those of you who are willing to correct us when we make mistakes so that the next time we get it right. And I love, I'm a storyteller. I love reflecting on the day that we were presenting our results initially to PCORI to hear, what we had learned. And one of the other universities that does an amazing job with engagement of the community, they had the same theme of, working with leaders, and they told this great story about how they worked with the head of the PTA and just how important, that was, and how the PTA helped them to get in. And there are those moments in which you just realize that you're in a, Twilight Zone episode or a parallel universe, because those were not the leaders from my study. I'll talk a little bit more about the leaders from my study later on. But one of the things that I love is the diversity of what it means to partner with the community and recognizing how diverse, because PTA was not, mentioned in any of the interviews that we did. That wasn't, the community that I was dealing with in West Baltimore. But the leaders from that community were there, and they just had great stories. And the lessons that we learned were the same, despite the fact that these communities were, again, from different walks of life. If we know why and how, when, and this is the part that conceptually we all get, but it speaks to the concept of not doing helicopter research, which is when isn't just at the beginning, at the end, it's in between. It's in between, right? So we all get that, yes, you want to do the pre-engagement, you want to keep people informed and engaged. We may not do that, but at least we understand that. The single loudest message that we hear over and over is this concept of in between the helicopter landings, which is you come, you do a study, the funding runs out, and then a year later there's more funding and you're back. And so I want to share my experiences, and I'd love to hear more. But my experiences are that, one, if you put on your right brain side, that yes, the community would like you to tell them what you learned. That the community would like you to tell them what you learned. That's easy. Second is that the community would like you to come back just to say hello, just to support their event that may not have anything to do with your research or even to do with healthcare. But just that, you told me that we were engaged. Well, I thought that that should mean a little bit of a two-way partnership. And hearing some simple things that are the ask. We know what the research ask is. I appreciated Marita's comment about my interprofessional collaborations, and one of my greatest lessons was from the colleague from the School of Social Work who's on the patients program with Robin and myself. And he said, your first question is always, what do you want out of this? And I thought, oh, that's simple. I can even do that, right? In other words, every time you go to a meeting, agenda item number one is, what do you want? What is your ask? And it's so simple but so powerful, for research to understand, oh, right. I said this was a partnership, but then I bring my agenda and I leave, at the end time for what you want. That's not a partnership, right? And so those are really some simple lessons that I've learned. And it's so easy to learn if you listen. Pecori talks a lot about the voice of the patient, but really just listening, allows you to really transform what we're doing. I'm going to present relatively quickly a 10-step framework that we developed for making sure that we engage individuals in what we propose are the 10 steps of conducting comparative effectiveness research, with the idea that if we do this, we would have patient-centered outcomes research. And I categorize these into kind of early parts of research, doing the research, and then what comes afterwards. And I suggest some means for doing this, but the means aren't completely mapped. So you notice that I put up some methods or some means for doing each of these first 3 steps, which is, what do people think we should study? What do people think we should study? What topics? What questions? Soliciting ideas. And then that prioritization process, where we really ask the community to help us prioritize. And then, as I mentioned before, once we know what we're going to study, to really go from a concept to a question that's meaningful to a patient, right? And many of us think that that stuff is already done by the time that we go to talk to individuals, right? We go in and say, would you like to partner on this research project? So that the research project is already defined. And I would challenge all of us to think about starting at the beginning of the research process, which is about thinking about what we might want to do, then prioritizing, and then figuring out what the question is. Sometimes we feel that only parts of the actual research project can be informed by patients as advisors, and that the rest is really about the human subject aspect. But when we look at these 4 components of doing research, which is deciding what are the alternative methods of treating a patient. We might know what it says in the clinical guidelines, but that might not be the relevant comparator for all of our patients. Mr. Jones, how are you currently managing your diabetes? Most of the time you won't hear, well, my physician follows the ADA guidelines, right? And so asking the simple question, how are you currently dealing with your child's mental health condition? Right? That's how we can elicit comparators. What is it that you currently are unable to do that you wish your treatment would improve? In other words, what outcomes are meaningful to you? When you decided to stop taking your medicine, what was it about the medicine that made you decide to stop? In other words, what are the harms that we call outcomes? The word outcomes is not in the normal vocabulary of people who don't do health research. So asking what outcomes are important to you doesn't always lead to the right answer, but reframing it in a question that patients can relate to and answer can get us the comparators and the outcomes. How is it that you're currently being managed for your condition? In other words, what interacts with what in building a conceptual framework where there are portals of entry to change an intervention that would improve your health? Don't just look at the literature on conceptual frameworks. Don't just use something that was published last year because you need a recent reference, but tailor it by asking questions about how people are being cared for. Analysis plan. Oftentimes, this is one that people give me the biggest challenge on is, how can a patient who doesn't have a master's in statistics tell you how to analyze your data? And I always say, well, how you analyze your data better be informed by what data you're collecting and how you're collecting it. Understanding why patient A makes different decisions than patient B explains variation. And you told me you wanted to analyze data to understand variation. So hearing stories about patient A and patient B's differences in preferences, in characteristics, in outcomes is important for you to think about when you're developing your analysis plan. And data collection. Here's when people say, oh, I get it. We can use community health workers to get data for us. No. That's not advisors. That's hired help. Mrs. Jones is a cancer survivor. And she remembers answering questions, and she remembered what it was like to get fatigued when she was responding to surveys. And she can tell us whether our survey instrument is too long. She can tell us whether she's willing to fill it out once a month or only twice during a study. And she can tell us what would have motivated her, even on her worst day with nausea and vomiting, to have given a daily response because something was so important that she would have found it within her to give a daily response to something that was meaningful to her. That's what we're talking about in terms of data collection. A good number of you are healthcare providers, and at some point in your training, you probably learned this teach-back method, which is I tell a patient about their disease or how to manage their disease, and then we say, Mr. Smith, given the conversation we've had today, what do you understand to be the best way for you to take your medicine? And we listen to see if they've understood what we're talking about. With our research results, we oftentimes just present them. We don't say, what was most meaningful to you? What did you understand these results to mean? Right? These simple tools that we've applied elsewhere can be applied to really engage patients as advisors, not as human subjects, in helping us to think through. If we have 5 tables, that's probably going to be whittled down to 1 bullet point. But that bullet point is going to be different for different types of patients. And so understanding what of the results is most meaningful to Mr. Smith versus Mrs. Jones helps us to think about how to present results. and how to translate results, sometimes literally from language to language, and other times, as we heard before, about putting it in the context of a different culture. And then finally, this concept of dissemination. One of the questions that we don't sometimes ask ourselves is, who owns the question? First time I was asked that question, I thought, I didn't even understand it. But now I understand it. We develop a question together, but then I think I own it. And so I get to publish the results. I get to make sure that I got everything out of what I needed first, and then we can talk about what you want to do in terms of dissemination. But if we jointly own a question and we jointly own a research project, am I willing to give up some of the stuff that makes me nervous if I didn't yet get tenure? Because I'm afraid that what you do may mess up my ability to publish the way I want. And at that point, does the partnership break down because you're threatening me? And if so, is that really a partnership? Did we really get engaged? Or did we get engaged on my terms? And these are such wonderful lessons, wonderful and simple lessons. But if we can remember these, it's transformative. It really is. The concept of lay summary is something that PCORI promotes, and I think it's fantastic. It's challenging, but again, if we develop a lay summary with our patient advisors, it really is a lay summary. And if you haven't done this yet, it's a great exercise. To see, you might have even run it through some software that tells you that you've got the phrasing right, but there's no software that can tell you that you got the phrasing right. And so really partnering with individuals who have been there with you throughout the process, so they understand what was done, and they can therefore help you to phrase what we learned. Research itself. I don't know about Ann Arbor, I don't know about Detroit, 'cause I know there's some people from Detroit here, I don't know about Flint. But I do know in Baltimore, Maryland, just the word research, sometimes makes someone not want anything to do with it. With good reason. What does that mean then during that pre-engagement period, in which if we haven't even agreed that we might participate in research, it's a little bit early to start talking about a particular study, right? And so understanding what research is, understanding the nuances in a community about how we want to be honest and transparent, but also move forward, right, is something that's a struggle. But again, when you work with folks from the community, you can learn how we can have this conversation and how over time, we can answer questions about historical atrocities in an honest and open discussion. Because the question's always in the room, even if it's not asked, right? So let's not worry about whether it's diabetes, hypertension, cancer, HIV, and AIDS. Let's worry first about whether this community is even on board at all. And if they're not, is there a way that they may be on board if we answered some questions about what research is and is not? We learned how to apply community-based participatory research principles for engagement. And it is that slow process of building and then maintaining trust. And many of you have learned the lesson that trust is very slow to achieve and very fast to lose. Trust is very slow to achieve and very fast to lose. So we tried to ask the community to help us think through what are those phases. And the first is just identifying who might be interested in partnering on a study. We also started using the word study because they felt that we'll get to research later, but the word study, is kind of the first step. And once we identified individuals, then there was that actual partnering. What would it mean? What is it that you want out of it? One thing that one of my mentors taught me is it doesn't matter whether people are willing to volunteer It is unjust to expect that the community should volunteer and we should get paid. And I understand because I have budget limits on my grants too. But, you know, that's not engagement. No, what's mine is mine and what's yours is negotiable is an engagement. Then explaining. Really taking the time to explain first what it would mean to do research, then what it would mean to do this research project, then how this research project would occur. And then the next is doing the actual research. We spent 15 minutes on this, and finally 3 members of the community just looked at us and said, it's just doing it. You keep trying to find a fancy word. It's doing research. That's what you're doing. You're doing it. Just call it doing. And then the last one, which is the one we always hear about, which is updating. And sometimes we think that updating means bringing that lay summary at the end of the study. Am I the only person who participated in your research project? That's a real question. Am I the only, do you have anybody else who signed up for this study before? That's updating the community. What proportion of your target population did you get? Are you at 50% now? Right? It's not just what did you learn, it's, I volunteered to participate. I'd like to know if the study is ever going to end, because some individuals have participated in studies that were shut down. And they didn't sign up for a study that was going to get shut down. They signed up for a study that was going to be completed and reported out. So they're a little bit suspicious about whether they're the only one who signed up for your study. That's updating. And yes, the lay summary at the end. But I think we think that updating is at the end. This is a continuous process, just like building trust is a continuous process. In this process then, there is this pre-engagement, which is before I can get to know you, I need to get to know your community, or as the woman in the back said, I need to get to know your culture. I may never fully comprehend someone else's culture, but I have to get a little bit closer to being able to do that. And, as we've heard, work with individuals who are from that culture who can help us to build that bridge. It is about sincerity and authenticity. It is about sincerity and authenticity, being genuinely interested in being engaged, not just partnering to get the research that you want. We heard a lot about getting rid of jargon, which we've all heard before, but we also heard about, well, do you ever talk to the other researchers? Because these questions all sound alike after a while. And in my city, where there's a name university 2 miles away, they wondered, do the 2 universities ever talk? Because the university that I won't mention, but their initials are JHU, was here last week. And now you're here, and if one of you answers that, the other one doesn't need to. And what a challenge that would be for us as researchers, to actually talk to each other so we don't waste time for patients, right? That's a higher level vision, that would build trust, that we valued people's time enough that we didn't waste their time by asking the same question they'd already answered, that if we talked with each other, we might be able to get. And then this concept of being there. I love the concept of just being there and what it meant. And it meant just that, which is that occasionally we see you here and you're not doing this. You're not getting something from us. You're just here to say hello, right? And that's probably the biggest request that I heard over and over is, we're more than happy to work on what's important to you, but can't you just show up to one of our events? And can't you just get other people from your campus? You work on a medical campus. Don't you know somebody who can come take blood pressure? Don't you know somebody who can tell us about the 80-20 rule? Doesn't anybody understand Medicare on your campus? Because we're confused. And just when we thought we understood Medicare, now they're changing it again. Can't you get somebody to come and just explain to us what was happening and what's happening? Doesn't anybody on your campus understand it? That's a reasonable request. And shame on me if I say, well, that's not really what this research project is about. So it's about building bridges. It's about building bridges. And I have found that the more different we appear to be, the more time it may take for those bridges to be built. Because we need to think about not just the person in front of you and yourself, but what my institution, what academia, what government has done, and that all of that is in the room when I walk into the room. Because I'm at a public university that's part of the government, and the government and my university and other universities have done bad things before. Right? And that's part of building trust, is addressing all of those issues. There is this pre-engagement that we talked about. I pre-engage with a community partner. The community partner needs to pre-engage with the patient. Imagine that you were diagnosed today with a horrible condition, and the physician said to you, I have some horrible news, and they gave you your diagnosis, and then they said, so your treatment options are A, B, or C. Which one would you like to start with today? Most of us would say, can I think about that? Can I go home and talk to my family? And yet, how many times do we send a graduate student into a clinic to recruit and consent on the same day? Here's a study, we'd like you to consent today. And that's a big decision, and we're asking them, without any prior knowledge of what you were going to tell them that day. Here's what we're doing, and we'd like you to decide today whether you want to do this or not. And so in the same way that there's a pre-engagement between institutions, there should be pre-engagement. Aurelia Laird, who's the research nurse whom we work with at our safety net hospital, she has this great way of, she knows everybody. It's a large hospital, but she seems to know everybody there. And she always says, okay, when you come back next week, I want to tell you about this study that we're doing with the University of Maryland on diabetes. And she sprinkles a little bit of details, knowing that they'll probably go home and have a conversation, so that when they do come back next week and she talks about it, that they'll be a little bit more prepared. Right? And then if they're still not ready that next week, there's still a bit more time. But just kind of understanding that there is a pre-engagement at both the institutional level and at the individual patient level, and that needs to be incorporated into our research. Respecting privacy. One thing that comes out loud and clear in many cultures, but particularly in minority cultures, is there are certain topics that should be, quote, kept in the family. And some of it is just understanding the rules of engagement, right? And respecting the rules of engagement. And if that's a truth, that it's a truth. And that there are some people and there are some topics that are just off the table, and that's got to be okay. In the same way that there may be some topics that are off the table from our side. Yeah. And that's part of respect and partnership. The one that's near and dear to my heart, since I spend a lot of time thinking about this, is what does it mean to do full spectrum recruitment? Not showing numbers that show diversity of people who are easy to bring into a room because, what was that woman? You remember the African American woman? Yeah, can we call her? That's not a hard to reach patient. That's an easy to engage patient because she participates in every study. Right? I mean, and getting beyond that, and the fact that you're sitting in a room and you're trying to remember the one African American woman who was in the study, that's a big problem, right? And so when you hear conversations like that, those are red flags that we're not doing things very well here. If we remember the one that's the one that will allow us to check the box, right? But really to work with these community leaders and to develop, a coalition of advisors who are willing to help to improve the way in which we conduct research. And we heard time and time again, diversity alone, by whatever measure, geography, age, race, gender, doesn't guarantee the full spectrum. Because there is so much diversity within whatever way you want to subdivide individuals, that we need to really think about the spectrum of diversity, not the boxes of diversity. And finally, this concept of giving back, which I've spoken about several times, which is giving back is not just the lay summary. But giving back is really being interested in what's important to the community. It may be $25,000 of materials left behind that would improve health, or it may be bringing a physician, a nurse, and a pharmacist to a health fair. And wouldn't it be nice if we could bring a lawyer? The lawyer is the one I get the most questions about. Can't you bring somebody who understands the law? And sometimes it's the law, meaning how does Medicare work? And sometimes it's how do I get my grandson's record removed? How do I get my grandson's record removed? And if you think that that's not part of how healthcare decisions are made, well, spend a little more time listening to patients. So let's talk a little bit about this, the term that I don't like, but the concept I love, which is this concept of recruiting individuals who typically would not be recruited into studies. If you can't quite make this out, what this is an individual who clearly had something bad happen to her and she needs to be transported by a helicopter for care. I would suggest that this is a hard to reach patient, right? Everyone agree? So who else is hard to reach? Who else is hard to reach?
Homebound people.
Can we get a mic so that everyone can hear?
I'm sorry. There are a lot of homebound people,
Yes,
people
there
that
are.
just cannot get out of the home,
there are.
paraplegics, so forth.
Right.
That just can't get out, or
Yes.
even they don't have the transportation, the availability of being transported back and forth easily.
Right.
Okay.
Right. I think that's great. And it's the question that we oftentimes get asked is, do you have transportation services? And sometimes researchers don't know the answer to that question.
Seniors
Seniors, yes.
are, for one reason or another, many times when they become elderly, they're not only homebound, but they are restricted from the community or reaching out to people in the community other than family, or a lot of times family is gone, and so they're just restricted because
Right.
there's no one to help them to communicate with other people, so it would be hard to reach them.
Absolutely.
It's people that they trust.
Yes, yes, yes. And it's interesting because there's a new focus again on elderly, because for a long time, an additional concern with elderly is you're kind of messy, right? We want diabetic patients. We don't want a patient who also has heart failure. That messes up my study. And good for the federal government that they're finally saying the target needs to be on people with multiple chronic conditions, because that's what many people face. People don't come in cleanly with just one disease, right? And I think that, to your point, that oftentimes if we're trying to reach out, it's again thinking about a trusted source that would allow us to bridge. But also eventually wanting to be there yourself too, so that it's not always borrowing trust, as I call it. So I can borrow trust through you to your friends, but eventually your friends want me to be trustworthy, right? So that journey. What else makes someone hard to reach? She's bringing the mic up to you.
Some of my colleagues in my office have a really hard time reaching the incarcerated
Yes.
and homeless
Yes.
because they're back and forth.
Yes.
And it's very, very difficult to reach them.
Yes, and we heard a great story about kind of misperceptions. And I love this. It's an anecdote, but a lot of what I've learned comes through anecdotes. Many researchers think that the homeless are a great population to go after because they don't have to go to work. And we heard, you realize if I'm participating in a study for an hour, if it's a certain time of day, that's $70 that I could have made out on the street. And that was so enlightening to a lot of researchers, which is, you might think a homeless person is sitting around all day. They're making money. And if you ask them to come into your institution that day or to meet you at the community center, That's an hour that they didn't make money. And so that's a pretty big ask. And it better be that the project is important to them. So I think you're right, that I think part of it is not seeing people, and part of it is not understanding what's going on in their lives. Let's take one more.
That speak different languages, language barrier.
Yes, that's great. Language barriers, and that comes on multiple levels. So it's people who don't speak English, but it's also literacy issues, and not just literacy, but health literacy. Some people are very literate, but not very health literate. All right, there's one more in the back, and then I'll go on.
That's one of the things I was going to say, but I would also say people who live in remote rural populations.
Yes. That's great. So one of the reasons I love working with Robin, other than she's just an amazing researcher in person, is that we call ourselves the bookends. Because she does rural, I do urban. I do beginning engagement, she does dissemination. You know? And really to think about all the different types of individuals. And to recognize that none of us are going to be able to outreach to all of these, because each of us has ties to certain communities, but if we work together, then we probably have a lot more ties than any of us individually have. So there is geography. I mean, I know this myself. One of the most interesting studies I ever saw by colleagues at my university was about the fact that there appeared to be this strange pattern of access to care in the state of Maryland that didn't make any sense until they took into account the seasonal effect. So what we saw is that in the eastern part of the state, that there were weird patterns of when people were accessing the hospital versus something else. And it wasn't until we realized that in the winter, you couldn't go over the mountain, you had to go around it. And so fortunately, software helps you to think through these things and seasonal effects. But I mean, there's a great thing where as a researcher, you sit there, but if you talk to people and they say, well, did you take into account the fact that, right? And anecdotes a lot of times are really informative. So when you talk about how can patients help us think about an analysis plan, they can tell you about variation, whether it's geography, whether it's culture, whatever it is. And so we do know that minority patients are oftentimes underrepresented for a variety of reasons, but we want to keep that in mind. We do know that people who are disabled or who have impairments are oftentimes not engaged. One of the greatest stories that I heard was from a patient who said, I've been blind since birth, and I've learned to deal with that. Nobody has ever asked me to be in a diabetes study, and my HbA1c is out of control. Why? Because they don't see him as a candidate for a diabetes study. They see him as a vision person, right? So just being aware that how you identify someone may not be how they identify themselves. And so we heard several of these. By impairment, by the illness that you have or the severity, by your age, where you live, social indicators, or what you do. I talked before about the other university that does amazing work, and it's not Michigan, it's another one. There's 3 of us, or at least 3 of us. And they stood up and they did this great job about the PTA person, and I had already done my slides, and so there's that point at which you kind of think, how am I going to say this? So I said, we heard about the mayor of the block too, but we're kind of an urban group, so the mayor of our block is the former drug dealer who doesn't want to see young people go through what he went through. And that mayor of the block is never hard to engage because they are motivated to help other people, right? And then people say, well, how do you get to know the mayor of the block? And I thought to myself, well, that one I even know. Like, how do you get to know? Ask anybody on the block who's the mayor. They know who the mayor of the block is, right? And so sometimes we try to over-intellectualize, like, well, I'd like to do that, but I don't know how to do it. It's not that hard. Everybody knows who the mayor is, right? But there are also professional organizations. There are cultural societies. And all of these places and institutions provide portals into a community. We heard a lot about some of the issues that were brought up before about language, and not just English to Spanish, English to Farsi, English to Korean, English to whatever, but English to a person who doesn't have a medical degree English. And we were reminded of the simple thing that we learn in pharmacy, medical, nursing, social work school of teach back, which is maybe what we need to do, instead of thinking that the IRB knows how to do informed consent, is to ask people, what do you understand this research project to be about? And make sure that they really do understand what they're participating in. And then finally, the greatest reminder is when we talk about hard to reach, asking the question that we may not want the answer to, which is, who's hard to reach? Who is hard to reach? Because sometimes it's not the other person on the other side of the mountain. Now, we might label the other person as hard to reach, but in their minds, they're not the issue, we are. And really coming to understand that, which is, have we set up our protocols in such a way that we've made it impossible for one who would volunteer to be able to participate? I close with a couple do's and don'ts. I try to have more do's than don'ts, so I have 2 do's slides and only 1 don't slide. For those of you who are involved in this, remember about shared governance and shared decision making. Remember that concept of who owns the question. Who owns the question? Right? Universities have lots of lawyers who protect the university to make sure that we own everything. Imagine you were getting engaged, and as you're about to get engaged, your soon-to-be partner said, just to make it clearer though, I'm keeping everything out of this entire relationship, right? And when you say it that way, it does make you feel a little uncomfortable with what we're doing. I want us to be a little uncomfortable because I want us to change. What is it that you would like? Not just, I need to get, between 8 and 12 African Americans, and you're an African American church. Can you help us with that? That's not a partnership, that's exploitation. It is a journey, so do remember that it's a journey, and enjoy the journey like everything else in life. Learn to laugh. One of the greatest skills that I have developed is the ability to laugh at myself, and to recognize that as a general rule, most people are willing to forgive you. And when you begin to understand that, and you're sincerely trying, that you kind of just are able to laugh at stupid things you do. So I always share one of my own experiences. I was planning on going back into minority communities, my comfort zone. I'd learned how to do that, and that was okay. I'd embarrassed myself enough time that I was used to embarrassing myself in front of minorities, so that was no problem. But when PCORI gave me the contract, they made me also deal with impairment communities, right? And so my first thing was having to talk to the blind gentleman, which term do you prefer? Do you like blind, do you like impaired? What do you, and he said, whatever gets you funded, I don't care. But I realized that was his personality, and that other people were not going to be so flippant, and so learning about language. So we get to the day, and it's time to do recruitment. And this is my first time, so we're about to perform our informed consent. Our IRB, I think, is pretty good, but somehow they forgot to tell me that I needed to have a process for consenting my blind patients. I figured that out as they were walking in the room. I thought, okay, this is great. You've learned, okay, this is just another time that you get to laugh at yourself, Daniel. It's okay, you'll get through this. Unfortunately, one of the participants was someone whom I knew. And so I went over and I said, can we talk for a minute? I said, I know you've done this before, so walk me through this. How do I do this? And he walked me through it. And we got through it, and we did it the right way. But thank goodness I had a tie to the community who was there for me, because otherwise, I don't know what I would have done. Now, in hindsight, I know what I would have done. In hindsight, I would have just gone up to somebody I didn't know, and I would have asked them. Because one of the things I realized is that if people are willing to volunteer, they're also willing to help you think through the things that you don't know. But at the time, I was so glad that I had my portal there to help me through that process, and I'll always remember that, and how important it is to have those leaders who are willing to help you along the journey. One way that I think about it is this 10-step framework. why we like that at the University of Maryland is it helps us to remember what we need to do, especially as we're training new investigators, right? And that eventually people don't need something like a checklist, but early on I think sometimes people like lists so they remember, oh, that's right, I need to do this step, I need to do that step. And so, you know, if you are thinking about this, using that framework will help to make sure that you are consistently thinking about engaging individuals, not just once or twice, but on a consistent basis. Remember that trust is earned earned slowly but lost quickly. It's earned slowly but lost quickly. But also realize that as with any relationship, you can lose, but you can rebuild. And so if you do lose, that you can oftentimes rebuild. And that when we think about diversity, that we think about the true spectrum, not just a box that's created by a government agency. And don't think just about someone from a subpopulation, but someone who within that subpopulation is harder to reach. And go after those individuals because their story is different and we need to hear everyone's story. Don't fake interest. People figure that out really quickly and that goes against trust. And don't give up. Be willing to make a mistake. Don't set yourself up to make a mistake, but be willing to make a mistake because it's likely to happen. And don't forget to be there. Really be there. So my final thought is, you know, if we're talking about patient care, helicopters are great. But if we're talking about patient-centered outcomes research, think bridges, not helicopters. Thank you very much. And there's about 15, maybe 10 or 15 minutes for questions. Or comments, because I love stories. So if you don't have a question, but you have a story, I'd love to hear that too.
I just wanted to comment back on the hard-to-reach populations, and we forget that parents of kids, because we're going after that certain child with that certain disease, and we forget that that parent also has other children, and it's hard to get that parent to come in and leave the rest of the kids. And so just to plan for the whole family to come.
Yes, it's very interesting when you talk family dynamics. So it could be a parent to a child, it could be a child to an elderly individual. I was talking with some elders the other day, and one of the things that they talked about is that they do need a ride to their healthcare provider. But oftentimes what happens is the research and the healthcare get all mixed together. And some of the elders are smart enough to understand the concept of HIPAA. And just because someone's my child doesn't mean that I want them to hear everything that I have to say, right? And so I think that, you know, family dynamics make it challenging. I heard from another visually impaired person that they were upset about a researcher who had a nurse who said, and don't forget when you come that you need to bring somebody to read the consent form to you because we're really busy in our clinic and we're not going to be able to read it to you. And the person said, but by reading the consent form, we're kind of disclosing what the study is about, and isn't that against HIPAA? And I thought, what a great question, and yes, I mean, and was exactly right. And so I do think that we need to do more research on understanding the family dynamics, both about engagement, you know, to participate, but then also engagement in that participation process, and things that oftentimes get overlooked. Great point. Comment in the back, and then one over here. And maybe we'll start here since she has the mic.
Thank you for this symposium. Thank you for the workshops, because I understand research a lot better and I'm not afraid to engage now. But what has really happened, I have learned how to have a relationship with my doctor.
That's great.
You know, having chronic asthma, you know, I would just be going to the doctor and whatever they told me. But now I know what questions to ask, what to do, and now taking better care of myself because of these symposiums. Thank you.
Absolutely. And thank you for the reminder that it's not about research, it's about improving health, and that we do the research to improve health.
Hi again.
Hello again.
Can you hear me?
Absolutely.
Well, you know, it's great that you brought up the family dynamic, because there are so many other things that come with a package of a family. And I don't know if I'm stepping out where I shouldn't, but I want to just say
There
this.
are no boundaries today.
When researchers get their grants, it should be something in that grant that would cover or help facilitate with making it possible that a whole family can come. And if that individual that is most interested in it, or the reason why they went in the first place, don't want portions or people of that family to hear things that's being said about them, there should be a different room or a different program that the family can go to be educated on how to give that kind of support to whomever it is that they're staying with. I mean, instead of grouping them all up in one room, but if they want to be there, so be it.
Yes.
But if they, you know, need to be in another room, or you got young ones to have some kind of youth care program going on with that, I think that would be great. I mean, because then you're really dealing with the family dynamic on a family basis.
I agree with everything you said. I mean, I have nothing to add. You're 100% correct.
Thanks. The comment over here from Cynthia actually triggered a thought when you were talking about journeys and meeting patients where they're at, as well as the trust that academic researchers need to build with clinicians. Because I think many times in patient journeys, they don't know enough to know what questions to ask. And if academic researchers are building relationship with clinicians, then that's teaching clinicians how to help them ask those questions.
So we're going to be we're developing a video archive, and we were talking with some seniors in video recording the other day. And we have this great clip where I said to the senior, "You don't seem like you have any trouble asking your doctor questions." And she said, "No, not at all." So I said, "Look into the camera and tell your best friend how to ask her doctor her questions." And I won't do justice to her if I tried to paraphrase what she said, because she spoke it so well. But we're going to post those kinds of videos, because patients speaking to other patients is very empowering. So I think what we need is we need more videographers in the world who can ask people who are a little bit further along their journey, and we have one here today who, as she said, you figured it out. We're going to capture that story. We're going to put it up, not so people in Ann Arbor can hear, but so that anybody who has access to the internet in the world can hear the answer. I think we have time for one or two quick questions before we go to break.
Hi, thank you. Hi, how are you?
Great.
Zachary Rove, Friends of Parkside in Detroit. I'm not sure if this is a question or a comment, or this is just a random thought that happened to just fly by as I was sort of sitting here. Earlier, you mentioned, or you talked about meet people where they are. And I hear that term a lot. And to be honest, I'm not exactly sure what that really means a little bit. But what got me to sort of thinking, in terms of meeting people where they are, I was thinking about, what if we meet people who they are? Which is a lot harder to sort of do. And I just want to sort of put that out there in the universe, just to get people sort of thinking about that a little bit.
I mean, what I would say to you again is, comments like that, again, what I think is important is for us to capture those things. Everybody knows how to get on YouTube, even I know how to get on YouTube, and make it available so that if somebody wants to learn what does that mean, that we can hear what it means to you and to 5 other people. And that one might be for researchers to listen to, right? So we're creating videos for patients, and we're developing videos for our researchers so they can listen to what patients are trying to tell them.
Can you develop some also for clinicians? Because when he was talking about meeting patients where they are, I was thinking as a doctor, and one who teaches residents, and I often use that phrase, meet them where they are.
Right.
I
Right.
think it's really more meet them who they are.
Yes.
And I remember this guy who came in with diabetes, and the resident was very frustrated. I'm telling you a story. The resident was very, which is usually your job, very frustrated because the guy hadn't gone to his diabetes class, and he hadn't learned about his disease and stuff like that. And I walked in the room and I said, so he's like on his smartphone all the time. Isn't there, you got to meet him where he lives.
Mm-hmm.
Isn't there an app for that?
Mm-hmm.
Can you give him some advice about what good apps are for learning about his diabetes?
Mm-hmm.
That worked tremendously. But we got to teach clinicians about that.
Yes, so I agree that we want to teach clinicians. I also want to clarify that many of you who are here, the old expression, preaching to the choir, you may understand this concept, but for many academic researchers, the concept of, I call it crossing Martin Luther King, because that's what it is in our city, but the concept of getting a person to geographically go to the community as opposed to expecting the community to come to the university is still a novel idea for some people. So part of the reason that I continue to say that is that in the same way that we need to meet patients who they are or where they are, we need to bring some of our researchers on this journey too. And one of the things I try to be sensitive to is, if we make it too uncomfortable for researchers, same as if we make it too uncomfortable for patients, then they don't want to get engaged. And so I'm trying to simultaneously engage communities and patients, but I'm also trying to engage researchers who want to improve health, but who are scared to do this new type of research that they don't understand. Right? And so it is about a journey and meeting people where they are and who they are. I think okay, I can't see what time it is, so I guess 7 more minutes, okay. It'll go on naturally in a second.
Okay. Carol Janney from the VA. I think another hard-to-reach population is those who do not have access to technology.
Yes.
And who are resource poor or low income. And I think that's going to be a bigger divide in the future.
Yeah,
And,
the
and needs
digital
to be
divide.
addressed.
The digital divide is a big issue. I think what's interesting is it is community by community, and there are some very low socioeconomic status communities that are very, up on the latest technology. There are some communities that even if people don't have phones, that there are lots of resources in the communities. And then there are other communities where there's nothing. And so, I think that we want to be aware of all of these issues and then find out in the communities that you're partnering with, what are they high literate or low literate in terms of technology? I thought you were going to also talk about veterans, because I think that's another group that can be hard to reach too. Working in the VA has some unique challenges, and I think there's been some tremendous research that's come out of some of the VAs across the country.
Hi, I'm Fran Talsma, and I have the pleasure of being a clinical research advocate from Mishar. And I want to follow up on what Zachary's comment about meeting people who they are. I think it really, we're all so eager to share our work and to engage our the patient populations or the community at different levels, but it comes down to just a base personal relationship of listening first. And so I would encourage all of you, when you go out to engage patients or to engage communities, to take the time to just listen first, listen then talk, rather than talk and then listen.
Great point.
From a logistical standpoint, I've heard a lot of great ideas about trying to help community members engage in research in terms of, I like the idea of having daycare available for kids and stuff like that, but from a practical standpoint, when applying for a grant through PCORI, are there limits on what you can apply funds for? I mean, when you're creating your budget, could you say you're going to use some funds to hire daycare workers to help manage kids while patients are involved in research, for instance?
This is a great question, which is that sometimes, whether it's PCORI or other agencies, that every agency have rules, and sometimes we use these rules as an excuse for why we can't do something instead of finding creative solutions. So it may or may not be that you can budget for a particular item. But one thing that I have learned is oftentimes when you're dealing with a setting, if you're truly partnering with them, that setting has the ability to kind of find those resources if you're coordinated. So as an example, when I work with the clinics at the University of Maryland, they can get transportation services for care, but they oftentimes cannot get it for research purposes. And so for those individuals, we do their research intervention either before or after they come for their clinic visit. Right? So that's a clever way to make it happen if we can't budget for it. I also know that you are allowed to pay partners from almost any grant funder to host an event. And so sometimes what I do is I give money to an individual to host an event, to use their facilities, and to kind of make it happen. And they know how to use that money to make it happen, and it's a legitimate expense on my part because they are providing space and services to get individuals there, and they know how to use that money for both the individuals who make it happen plus whatever else has to happen. I don't ask questions I don't want to know the answer to, and it all works out fine. So all I need to know from them is how much money will it take for you to do what we need done? And then I put it in my budget. So, there are some questions that sometimes we don't ask, but that's how to make it happen. And I think even if AHRQ or PCORI were watching this video, I think they would be okay with that. We do need to be fiscally responsible and follow the rules, but if the rule says that I can pay somebody, to put on an event, and I pay them to put on that event, I don't know which part of that money they use for that and what part they use from their own, but as long as they can figure out and they're not breaking any rules either, then we get our research done and everything works out okay. I think what happens sometimes is universities don't want to pay the partner. They only want to give out the $25 gift card, right? And I don't think that's right. If I'm asking a partner to participate, they should be compensated for partnering, right? I know that the church secretary is not going to get fired if I don't fund the church to have her help me, but she's spending some of her time. The church should be reimbursed for that. Okay. So I think now we actually, okay, are done.
Okay, I thank you so much for the information that you have shared with us this morning, and over through each slide, I continue to say to myself, he really gets it. I love the fact that you care about what is happening on the other side, and I'm going to give you an example. I was in a doctor's office and the technician was trying to take blood, and she kept missing my vein. After about the third try, I stopped her and I said, "That hurts." To which she replied back to me, "No, it doesn't." That to me is serious, very serious. And if researchers and medical field people respond to patients and communities in that same sort of way, then we have a problem. We have a serious problem. Things that may cause us to respond and say, "Ow, that hurts," needs to be listened to. And the medical profession cannot respond by saying, "No, it doesn't," just because it doesn't hurt them. So I thank you for the empathy. I thank you for the understanding that the community, the people that are being researched, have to be true partners in not only what is going on, but the results of what is happening. Thank you.